Hi there. Have you ever been told that a functional neurologic disorder is a garbage can diagnosis? A diagnosis where every doctor might just throw it on when they can't figure it out. I have heard this from people time and time again, and it's just not true. And there are so many reasons why functional neurologic disorder is a positive diagnosis, not a diagnosis of exclusion. So this is what we're talking about today. And there's a brand new review article out that I want to share with you. I realize I didn't even introduce myself. So if we haven't met, my name is Julie Hirschberg. I am not a diagnostician. I am a neurologic physical therapist. So I don't give diagnoses out, but I meet people with diagnoses every day and hear their stories, and particularly about the process of diagnosis. I usually hear about it when it goes wrong, but I tell you, sometimes it goes really right. And I want to tell you what that should look like so that you can advocate for what you need if you have a functional neurologic disorder. And if you are a therapist working with somebody with a functional neurologic disorder, to really be able to help and guide them to a person that might be able to give the positive diagnosis. So let me give you the name of this article that we're going to touch on today. It was a review article that just came out. And by the way, if you are not on our newsletter, get on our newsletter. I always send out the articles that we talk about during the week. This one is by Mark Edwards. He's like a giant in movement disorders, by the way. Mark Edwards, it's a review article in clinical neurophysiology practice, and it is called Clinical Neurophysiology of Functional Motor Disorders. And it is literally a handbook chapter on this. So helpful. I love a good review article because it synthesizes a lot of different areas of research so that we can understand it. Now, I have to tell you also, I'm not a neurophysiologist. I read a lot of papers. I teach neuropathology, for which I have to understand some neurophysiology, but this is not my expertise. But there are some key takeaways in this article that I can at least interpret for you all. But I just want to put a disclaimer. I don't do these types of tests. A neurologist would order. A neurologist with a background in neurophysiology might do these tests. We're talking EMG and EEG. These are not tests that I do. But I'll look at the results and help somebody understand them. Yes. And in fact, I got to tell you, even as I was reading this article, there's one particular word. I literally had to Google, how do you say this word? Because I didn't know how to say it. So I just want to give that disclaimer. But let's start off with what are the positive diagnostic findings in functional neurologic disorders. So first off, functional neurologic disorder is a clinical diagnosis. What does that mean? Clinical diagnosis means that it is based on clinical findings, meaning clinical tests that the neurologist would do with you. There are many neurologic disorders that are clinically diagnosed. One of the biggest ones is Parkinson's disease. It can very, very soundly be diagnosed based on clinical exam by a neurologist, and doesn't rely on diagnostic testing for confirmation of the diagnosis. Now, there is a DAT scan for people with Parkinson's, but it's not necessary for diagnosis. It's a clinical diagnosis. So same thing with functional neurologic disorders. It is a clinical diagnosis based on key distinct tests and measures and patterns that we see. This is how a lot of neurology is based, is on patterns. So what are those things that we see in functional neurologic disorders? So variability is a key piece of the clinical diagnosis. If somebody has tremor and trainability of that tremor, meaning the tremor trains to another frequency and changes frequency. That's a piece. Suppressibility of the symptoms. Oftentimes, you may see in the time course remission of symptoms and then a reoccurrence of symptoms, but sometimes you don't. So that's not the only factor. And one of the biggest things with a functional neurologic disorder, because this is part of the pathophysiology, is that it can change with attention to the symptom. So these are the positive clinical diagnostic factors in FND. Now, there are actually clinical tests that a person can do to test each of these factors. So things like the Hoover test, this is very sensitive and specific for functional weakness. There's a similar test to the Hoover test, and that is the hip abductor test or adductor test. Abductor or abductor? I think it's abductor test. Also helpful in the diagnosis of a functional paralysis. So there are distinct tests and measures for each type of functional neurologic disorder. So the Hoover test for weakness, entrainability for tremor, there's specific patterns of muscle contractions that are seen in functional dystonia. So those are all clinical exams, some more sensitive and specific than others, but have been repeatedly found to be positive in a person with a functional neurologic disorder. So if you were wondering, like, what might this be similar to? Well, let's go back to Parkinson's disease. One of the tests that is done in Parkinson's disease is called the UPDRS, the Unified Parkinson's Disease Rating Scale, I think, is what that stands for. And it looks at different hand movements, a person's expression in their face, their cognition, and so on. And it's very reliable for screening all of the different parts that could be involved in Parkinson's. Now, we don't have a UPDRS for functional neurologic disorders, but gosh, that'd be a good idea. But those tests bring out a particular pattern of symptoms. In Parkinson's disease, we see a slowness of movement, we see decreased amplitude of movement. And so those tests are positive, and we go, these are positive findings of Parkinson's disease. So same with a functional neurologic disorder. And this is if you have FND, when you are tested with a neurologist, they would say, I'm doing this test. And when I do the Hoover test, I test this side, I test this side. On this side, we can see this is a positive sign of functional weakness. And here's why. And here's what that means. And same thing with tremor. I see the entrainability of tremor. And here's why. And here's what that means. Those would be positive signs and really specific to a functional neurologic disorder. And that is what, if you have had, if you're a clinician, you have a patient maybe uncertain of their diagnosis, or if you're a person with FND and uncertain, you would be seeking somebody that would do that testing. This would typically be a neurologist, and you'd have those positive clinical findings to support the diagnosis. What we don't want to see is that just a diagnosis of exclusion, meaning they've done every test under the sun and ruled out everything else, and therefore it must be FND. That is not how it's diagnosed. That's not how it should be diagnosed. And that is really an error of diagnosis. It's not a garbage can diagnosis of like, we can't figure things out. It has positive clinical signs that are testable. So there is actually, I didn't bring it up for this talk, but there's a great review article with all of the positive signs in FND with this huge table and sensitivity and specificity of those. If you're one of our Brain Bites members, I know we have that in our resources, but I'll see if I can pull that up as well. This particular study actually was looking at beyond the clinical signs and symptoms, what are some of the diagnostic tests that we can do with electrophysiology that would support the testing? So the clinical test informs us. You can have a positive diagnosis of FND without any diagnostic tests. You don't need an MRI. You don't need electrophysiologic testing. But you can, and there are some validated electrophysiologic tests that can confirm certain things. And I was asked this, we did a webinar with FND Hope just yesterday. Wow, it's been a long day. And somebody asked, like, why aren't they doing fMRI or PET scans? And those are not yet validated as diagnostic tests in FND. But I'm going to tell you a couple of the things that are. I don't see them widely done. I will say that. But they are regular tests that are done, and there are specific patterns in FND. And I think this is really cool. So again, let me just bring up the title of the paper was called Clinical Neurophysiology of Functional Motor Disorders. And this is a whole handbook chapter. And again, the first person on this is Mark Edwards, first author. So what I love, I'm going to actually read you a quote from this, is in a lot of neurology, the early understanding of FND was that it was incongruent with other neurologic disorders. There's a problem with that as a pure criteria. I mean, first of all, it's not pure, but here's what they say. This is a rather problematic criteria as it makes an assumption that patterns of symptoms and signs typically seen in typical neurological disease are all known, which is untrue. That is a revelation, I think. That is such a helpful sentence in this article. It is problematic to think that we're all knowing about every sign and symptom of all neurologic disease. We just don't. We discover new things all the time. So if we only adhere to this idea that the diagnosis is just incongruent with other neurologic diseases, that's not helpful. That is the definition of a diagnosis of exclusion, meaning we exclude other diseases. That is not helpful, and that is also not what FND is. It's a positive clinical diagnosis. Now, like other disorders, often what we do is rule in the diagnosis with positive signs. We also rule out other things. It doesn't mean we don't do that, but what it means is that is not the only way that we do this. So one of the things that they start off in talking about is that neurophysiology has actually been very helpful for many years. This is not new, but many years in functional movement disorders, particularly tremor and myoclonus. So I'm going to hit on those today because they have positive signs in neurophysiologic testing. So let's talk about functional tremor. And this was really interesting. They cited a recent study that found that electrophysiology, so these physiologic tests, was used by 60% of movement disorder specialists on a regular basis to have a laboratory supported diagnosis. That is awesome because I have not seen that. But in this study, it was a survey study of movement disorder specialists, for which we work very closely with movement disorder specialists. They use electrophysiologic testing to support a diagnosis. This was specific to functional myoclonus and functional tremor. Now, they also said a third of people didn't even have access to this kind of lab study. So I want to be mindful that not everybody is going to have access to this. So typically what a person would do and go through from a diagnostic process is have the clinical exams, have positive findings, and then they could have laboratory supported findings. So those findings in tremor, let me talk about what they look like. So I'm going to actually bring this up because they talk about a specific study that looked at a battery of tests done electrophysiologically for a functional tremor. And so a battery of tests is often much more helpful than a single test. And that's true throughout neurologic disorders. So what they looked at was tonic co-activation of tremor at onset. This means activation of muscles of both sides of the joint. This can be looked at by doing EMG. So they would have a needle EMG in muscle so that they could look at that activation. Again, I don't do this test. This is my interpretation of the test. So they look at tonic coactivation of the tremor. They look at tapping performance at 3 different frequencies, remembering that a functional tremor would typically change frequency. So they look at frequency shift. They look at the suppression of the tremor. They look at entrainment with tapping. And they look at response to ballistic movements and loading of the limbs. And somebody's saying here too, that was it. It was the EMG. So maybe you had this. So I guess 60% of movement disorder neurologists are actually using this to help differentiate functional tremor and myoclonus. And so in this study, they looked at this battery of tests and found that it was highly sensitive and highly specific. So 89% sensitivity, 89.5% sensitivity, 95.9% specificity. That's very high for both of those, to distinguish people with functional tremor from other tremor. So very, very helpful. And this study, gosh, was from, I want to say 2018. So, if you are a person with a functional tremor that still has uncertainty with diagnosis, it can be diagnosed clinically very clearly. But if there's still uncertainty, you may be able to see a movement disorder neurologist who could do electrophysiologic testing to confirm it. It is not necessary. And in fact, it's kind of painful and time consuming, and you might not want to do it. Personally, if I have functional tremor, I wouldn't do the neurophysiologic test. I would go by my clinical test because I don't want to go through that painful test. And I see somebody asking for the DOI. I actually will put it in the comments, the caption of the post. I'll put the DOI of the study. Again, it's available free full text, and it's called Clinical Neurophysiology of Functional Motor Disorders, IFCN Handbook Chapter. So we talked about tremor, and that there are some positive neurophysiologic testing in tremor. I think the other thing that is so helpful is that there are these clear patterns. I think it even kind of solidifies even more. People are not making this up. They're not making up a functional tremor. It's a very real thing and has a very distinct pattern electrophysiologically. So let's go on to functional myoclonus. This is something that we actually see quite frequently. And again, this is something that can be tested, this time with a combination of EEG, so that's electroencephalogram that's looking at brain activity, and EMG. So they combine that. And this also is done to distinguish other forms of myoclonus from functional myoclonus. Myoclonus, by the way, is a jerk of, it could be of the limb, but we typically see it in the trunk. And it's I shouldn't say common. Just because I see it doesn't mean it's common, but it is one of the more common forms of a functional movement disorder, is the presence of myoclonus. So this was the word that I had to look up. I've seen this word numerous times. I've never heard it said, but when they're doing this testing, they look at a readiness potential of the brain before movement. And I'm not going to pronounce it exactly correctly, but it's something like Bereitschaftspotential. potential. So potential is the last part of it. Bereitschafts is the first part of it, of the word. I believe it's a German word, so it's probably Potenzial. But this is a readiness or premotor potential that is seen normally in folks before they move. And it reflects a normal activity that occurs in the brain prior to a motor response. So here's the thing. In myoclonus, this is often absent. But what they found, and again, this review is kind of reviewing multiple articles, in folks with functional myoclonus, it's there. It is present. This premotor readiness potential is present in folks with functional myoclonus. And there was 2 studies. It is very interesting. I have Ethnicity Gardens on here who had EEG, and EMG. I'm so glad you're here. You're like a pro. I haven't had these things done to me. But it's very interesting. So in 2 studies, they found that not everybody with functional myoclonus, but 47 to 86% of patients with functional jerks or myoclonus had the presence of this readiness potential. Nobody with other forms of myoclonus had this. So this is actually diagnostic in both ways, right? So this is helpful in to diagnose functional myoclonus, and it's helpful to diagnose other forms of myoclonus, because the person with other forms of myoclonus would actually be missing this normal readiness potential. Now, there are other things that they found that differentiated people on this EEG and EMG. They found, and again, I'm not a neurophysiologist, but they found some desynchronization components that occurred before the onset of a functional myoclonus that don't occur in other types of myoclonus. So again, this becomes a neurophysiologic positive sign to confirm a diagnosis. So very helpful, right? I think this is so very helpful. Now, I want to point out that in this article, they also talked about how we don't have neurophysiologic testing that helps confirm functional weakness or functional dystonia, functional gait disorders. There were a couple of others that they said, there are some studies in these areas, but not like we have for functional tremors and functional myoclonus. So there's some work to do there. I think the bottom line too, they weren't proposing that everybody needs neurophysiologic testing. Again, this is most helpful when the diagnosis is not clear clinically. The other thing I would say is that these are done by a movement disorder neurologist. And I always tell people, if you have a functional movement disorder, so a subtype of FND that is dystonia, tremor, myoclonus, anything that's involving movement, you should be seeing a movement disorder neurologist. That's a specialist who can distinguish clinically between a functional movement disorder and something like a myoclonus, a hereditary disorder, a genetic disorder. I think you should have that testing done. And yes, it often takes a long time to get into a movement disorder neurologist. I'm not going to lie. I know around here in Los Angeles, it can take up to 6 months. There's not a movement disorder neurologist on every corner. So I know that can be a barrier. I know it's a barrier in other countries to find a movement disorder neurologist. But if you're working with somebody that has questions of the diagnosis, if you're uncertain of the diagnosis, I think a movement disorder neurologist is most helpful. And I'd ask about their experience with functional neurologic disorders, because getting a diagnosis where the person is just saying, well, I can't figure it out, so I'm just going to call it FND. That's not acceptable and not appropriate. You really want something based on positive clinical signs and symptoms. And I wouldn't take the garbage can. And that is not the definition of FND. I would say it over and over again. And I think when people have gotten that experience, it's really demoralizing. And by the way, I welcome questions. So I see some questions and comments coming in, so I'm going to scroll through these. Great. We found some folks that had the article, so that's wonderful. And some folks have seen multiple movement disorder specialists, and they don't seem to agree. And this can also be really confusing and really hard. So especially with dystonia, that's what this person is commenting on. I'm going to tell you clinically what I often see in dystonia. I see both. So I work with people with genetic dystonia, people with Parkinson's and dystonia, people with runner's dystonia or task-specific dystonia. And those are kind of idiopathic dystonias. Often I also see they have a component of functional dystonia. And both respond really well to therapy. So there are, for the person who has gone down that pathway of multiple physicians and multiple doctors and they don't agree, but the diagnosis is really responsive to rehab, sometimes it doesn't matter. And I'm going to say that I'm not going to say your diagnosis doesn't matter. That's not what I'm saying. From a rehab standpoint, people do extremely well, whether they have dystonia or functional dystonia. They can respond really well to neurologic rehabilitation. So if you're getting frustrated in the diagnostic process, if you're tired of going to physicians, I would say go do therapy. That PT, OT, psychology, absolutely. Speech therapy as well. Somebody else had come, still no testing for CRPS either. Right, there's CRPS, complex regional pain syndrome, is another clinical diagnosis. It does have very clear diagnostic criteria. like migraine, has really clear diagnostic criteria. 3PD, persistent postural perceptual dizziness, very clear diagnostic, clinical diagnostic criteria. If you meet those, if you meet those clinical criteria, I would say pretty comfortably that you have CRPS. So that is one disorder that has very clear clinical diagnostic criteria. Have other folks saying I'd love that resource. So again, I put all of our resources into our newsletter. I'm going to have to go digging for that one that I talked about with the table of all those diagnostic tests. So another person commenting, I have EDS, Ehlers-Danlos syndrome. That's a hypermobility syndrome. That's another umbrella diagnosis that we shouldn't throw everybody into either. So again, that also takes careful physician, clinical, and diagnostic testing for. We do see hypermobility a lot at Re+active. We work with a lot of people with hypermobility and EDS, and there's a lot that can be done to manage it. I do want to tell you that. So let's see here. So many great pieces. Okay, Ethnicity Gardens was also saying, had the EMG, didn't feel anything, unfortunately. And this person is saying, unfortunately, because they couldn't feel, didn't have the sensation. And lack of sensation is something that we see in functional neurologic disorders. Certainly might take a needle EMG test that might make it more comfortable, but that's not what you want. You want to be able to feel your legs, for example. I am hopeful for you, Ethnicity Gardens, for getting sensation returned. I have other folks commenting they're still trying to get a movement disorder neurologist. Oh, Betsaida, hi. Any imaging EMG guidelines for FND seizures? Yes. This was not in this particular study, but there is another resource that looks at EEG findings in functional seizures. Functional seizures are another one that can be definitively diagnosed with EEG. There's clinical diagnostic features, and then there's clear EEG features that distinguish it from an epileptic seizure. And we know that there are folks that have both epileptic seizures and functional seizures. And the good news is that with EEG, we can distinguish those. So I'll have to pull up a resource for you, Betsaida. I know you're in our Brain Bites group, so I will send that to you. There are distinct criteria for that. Yeah, and somebody else is saying, I'm tired of dancing with my insurance. Oh my gosh. I am tired of dancing with everybody's insurances. I feel like insurances purposefully dance you around so that you give up and then they don't pay for things. Oh, somebody else is asking, do you use the FMDRS? So, because I was talking about the UPDRS, I don't like it. That's a really good question. And I have not really liked it. And I've talked to other colleagues who don't like it. But honestly, are you using it? This is Marcella, maybe. Thank you for the comment. Are other clinicians using it? I want to know. But it's also not published a ton. So the UPDRS in Parkinson's is used a lot. So the FMDRS was kind of looking to be a similar thing in functional movement disorders, but it just didn't, the uptake wasn't high. It hasn't been researched a ton, and it just wasn't as helpful for me. But I would love to hear how you're using it. Ethnicity Garden says, thank you. The test was in 2021. I still can't feel all that well, but I hope that you're getting some sensory testing and treatment with a really good PT and OT. I want to tell you that sensory symptoms can improve, but they take some testing and treatment. Let's see. Oh, Great. Ethnicity Gardens also says, I have improved greatly since getting into an FND program. Yes, I love hearing that. Okay, thank you, Marcella. So has been using the FMDRS with a patient to report changes in frequency and intensity. And this is one of the things that I think can be really challenging in functional neurologic disorders. So your comment made me think about this. And again, this kind of comment is really for the clinicians out there that are looking for good ways to test this. One of the things that worsens people's symptoms in functional neurologic disorders is attention to the symptoms. Yet some of the ways that we test this are to bring attention to the symptoms, like asking a lot of questions. How much are you having them? How frequently, etc. And it can actually make symptoms worse, not because the person is faking it or malingering, but because the attention centers in the brain are driving, I shouldn't say driving, they've kind of gone awry and they are contributing to the symptoms. So it's one of the reasons I don't like a particular symptom tracking measure. But I do understand the clinical usefulness of actually seeing that symptoms have decreased. At Re+active, we do some symptom tracking, but I would say it's less. I think one of the biggest symptoms that we'll look at tracking is in functional seizures. But what we look at more is a person's function. And how are they able to function? Are they able to walk when they were in a wheelchair, for example? So we do a lot of functional testing and measures versus very specific symptom tracking. Now, I say that, and this is Ethnicity Gardens. This is for you. We do a lot of testing of the different systems that might be contributing to symptoms. So I think this is probably where we spend more of our time is in autonomic testing. So we might do some baseline autonomic testing. We might look at it with treatment, and then we can see a change and improvement, for example, in heart rate variability or Buffalo concussion treadmill tests, for example. So those things we would see. We look at sensory testing. So this was for you, Ethnicity Gardens. I'd like to see that somebody might be doing some sensory testing and testing different modalities. So whether that is 2-point discrimination, touch, pressure, temperature, vibration, weighting. So we would test those before and after. And I find that not only do those things improve, but testing those things actually inform how we're going to treat. So again, asking about symptoms is really, really helpful to understand the picture for a person, but it doesn't actually get to the underlying, why are they there? What is the autonomic piece? What's a sensory piece? What's a motor control piece? What's a lifestyle piece? But thank you so much, because now it makes me want to kind of go back and look at the literature for this. So somebody else is commenting here. Minnie Moon, I love that, is saying it's hard for me to ignore my symptoms as movement, talking, eating, reading, visual, auditory set mine off 24/7. Yeah, and you shouldn't ignore your symptoms either. So I think not ignoring or suppressing symptoms is not the answer in FND at all. Being able to live life with your symptoms, live life despite your symptoms, and understand the underlying components so that we can treat them would absolutely be important. Another great question was, what if FMD is intermittent? It's frequently intermittent. And we would want to figure out why. by the way, we don't always know why, but we would want to get to the underlying. When I find things that are intermittent, I will tell you, I'm going to look at the autonomic nervous system. I'm going to look at the sensory system. I'm going to look at lifestyle and psychosocial pieces, because those are all intermittent things in our day-to-day life that we often don't have control over. And sometimes they all kind of build up and accumulate, and then we have the symptom. And so those are the pieces of the pie that I'd like to look at for intermittent symptoms. Oh, really great. So I keep telling Ethnicity Gardens things to do in therapy, but yeah, so all of that's done. It was so sensitive, I had to stop. Yeah, so that's another piece actually, is the sensitivity of the nervous system and what we might or might not be able to test in a session. And I often find that many modalities of sensation, we can't test them all at once. It sends the system into overload. So thank you for saying that. Bree is saying hi, Julie. I'm going to say hi, Bree. I love you. I'm so glad you're here. Dana's here. Hi. Well, I want to thank you all for joining me for this conversation about diagnosis in FND, for your great questions and comments, for teaching me all of the time. So I appreciate you. I want to remind you, the article again is called Clinical Neurophysiology of Functional Motor Disorders. It's the IFCN handbook chapter in clinical neurophysiology practice. I'll put it in our newsletter. I will put a link in. And if you're not in our newsletter, you can sign up online if you're a patient at reactivept.com, if you're a clinician at reactiveeducation.com. And oh my gosh, I have to tell you one more thing. We are doing a free class for people with functional neurologic disorders. In fact, it's our very first masterclass, meaning we're kind of taking all of the pieces of functional neurologic disorders into a class that is useful and helpful for people with functional neurologic disorders. So we are doing this on February 22nd. It's live. It's a Thursday at 5 p.m. I know that doesn't work for everybody's time zone, so we will record it as well. You can sign up on our website at reactivept.com/FND, or you can send me a message and I'll send you the link to sign up. But at least once a year, we try to do a free class for everyone to educate and to empower. There's so much that you can do with just the right resources. So I'm super excited for this. I've been preparing it. I've been working with our team. But go sign up. If you're a clinician, hey, send this to patients too. I think it will be really empowering for them. So go sign up, reactivept.com/FND. And yay, we have folks that are signed up. I'm so glad, because then I get to meet you. It will be on Zoom, and on these Instagram lives, I don't get to see your faces. So on Zoom, I get to see your face. That will be so nice to meet you. And we will talk all things FND for people with FND. And again, that's February 22nd, and you can sign up at reactivept.com/FND. And if you can't join us live, catch the recording. So thank you so much. I enjoy these so much, and I enjoy chatting with you. So I will see you again soon, and hopefully I'll see you on February 22nd too. Thanks so much. Good night.